Warami. Hello. Wujirigamarua. Welcome. My name is Craig Madden, and I'd like to start by thanking the National Drug and Alcohol Centre, along with the University of New South Wales, for inviting me here today to welcome you to country. I'm a proud Bundjalung Gadigal man from the Eora Nation, and Gadigal land is the land on which we are standing here today. Jinyara Gadigal. This land is Gadigal. It is our customary for our Aboriginal people, when we invite you, our guests or visitors, onto our land or country, that we offer you safe passage as you pass through and sit on our lands. So as a proud Gadigal man and a representative of the Metropolitan Local Aboriginal Land Council, I'd like to welcome you all to Gadigal land, Aboriginal land. I'd like to pay my respects to our elders, past and present. They're the storytellers and the knowledge holders of our people. And I'd also like to acknowledge the ancestors who watch over us as we walk on these sacred lands. To our Aboriginal brothers and sisters, if we have any brothers and sisters from the Torres Strait Islands, welcome. To all our non-Aboriginal and Torres Strait Islander brothers and sisters here today, a warm welcome to Gadigal land, Aboriginal land. Our Gadigal clan is one of the 29 clans which make up the Eora Nation, a nation that's bound by 3 distinct landmarks: the Hawkes River to the north, Nepean River to the west, and the Georges River to the south. Within the boundaries of those mighty rivers lie our Eora Nation, and the land that we gather on here of our Gadigal mob are one of the many clans of that nation. To our guests who've travelled from across the seas, for those who have travelled from across our great country, great state, to this magnificently beautiful city of ours, which is going to be hot today, welcome. Hope you all enjoy this. I've worked in the Department of Communities and Justice for the last 18 years, working with drug and alcohol affected people every day. So this is an important space that we work in. So I hope you get some wonderful outcomes at this symposium today. On behalf of the Metropolitan Local Aboriginal Land Council and its members, our Gadigal mob, for those of you who are travelling afar this afternoon, please travel safely. And once again, welcome, welcome, welcome. And lastly, I think it's important to remember that under the asphalt and the grasslands and the waterways of this beautiful country of ours always was, always will be Aboriginal land. Thank you.
Thank you very much, Craig Madden, for that beautiful welcome to country. Now I'd like to also welcome in-person and online attendees to this 2025 NDARC Symposium. I'd like you both in person and online to refer to the event handbook, which is available, which has all the information, particularly on how to submit questions, vote in the People's Choice Poster Award, and provide feedback on the event. All the sessions in the symposium today are being recorded and will be available on the NDARC website post the event. Now, it's a special honour for me to introduce Dr. Norman Swan AM. He tells me his claim to fame is that he once nearly became one of the founding directors of NDARC. He has clearly fame way and above and beyond that, but he has been a constant supporter to NDARC over the ages, and we thank him very much for that, and he needs no further introduction. I'll let Norman take over.
Thanks, Mike, and welcome to you all. It's like old times. All of you gathering here today. A lot of new faces, which is fantastic. Young researchers developing. So I actually did get on the board of NDARC and was there for many years. And we went through interesting times. Those of you who remember those days, there were some interesting times. Interesting moves in terms of accommodation. Now you seem to be moving towards where you always should have been, which is permanent plush accommodation. The health report would not survive without Mike and Louisa particularly appearing on it, almost weekly with their latest research. But it's fantastic to be here. And we are going to talk about the National Drug Strategy. And I've always had a passion about this area. And when Hawke came into power, he and Mick Young, the Minister for State, wanted a drug war. They had swallowed the American line, hook, line, and sinker, that what we needed to do was interdict, punish people, zero tolerance, abstinence. And from memory, it took Mick Young to be changed, and it was on a trip to New York. And if you remember those days, parts of New York had HIV transmission rates equal to Kinshasa. And I think there was only one needle exchange in the whole city, and it was next to a police station. Mind you, the first heroin injection center in Switzerland was just next to a cop station as well. But then there was, sense prevailed, and it was realized that harm reduction was the way to go, and they were convinced of that. And there are many people in this room, some of whom transformed from drug warriors to harm reduction, and who helped to convince the government of the day, a Labour government which should have been progressive, to be progressive and be true to its roots. And NDARC, the Centre in Western Australia, are inheritors of that tradition, that proud tradition of harm reduction, and we led the world. You wouldn't have the Kirby Institute without the prevailing attitude towards drug use. The gigantic impact that Australia's had on the world in this area is hard to minimize, or exaggerate, I should say. So where are we now with a national drug strategy? In an era where the President of the United States stands up and has trouble pronouncing acetaminophen. We should have told him in Australia, it's just Panadol, let's go for it, mate. And where science, not that it was ever terribly strong in government in terms of evidence-based policy, evidence-based practice, but it's fragile internationally, and you have blackmail going on internationally. And don't forget, this is not new. The United States of America has dominated drug policy internationally, and its drug war attitude towards opioids has poisoned drug policy in many nations around the world, because regardless of administration, they were quite happy to blackmail other countries to copy their policy on opioids. And the last thing they wanted was a heroin injection center in Bern or in King's Cross or elsewhere. So where are we now? Where are we going? Good time to take stock. So let me invite our panelists up. Mel Miller, Professor Mel Miller, who's actually chair of the NDARC. Come up as I introduce you, if you don't mind. Chair of the NDARC Advisory Board, deeply involved in this policy area for many, many years. Been a board member of NDARC for many years, chair since 2003, and is Professor of Health Policy, Economics and Evaluation at Griffith University. Associate Professor Robert Eli, who's public health physician, specialist in addiction medicine, but also heavily involved in policy at an international level as well as state level, was clinical director of drug and alcohol services in South Australia, and expert advisory for WHO on drug dependence and alcohol problems. Dr. Mary Harrod, who is chief executive of the National Users and AIDS Association, NUAA, peer-based organization, incredibly important, and again, something that Australia has, if not pioneered, certainly been very strong, that you can't get very far without peer-based organizations working particularly with drug users and preventing the spread of bloodborne viruses on the ground. That's what America failed to do in the early days of the HIV/AIDS pandemic. And last but certainly not least, Associate Professor Michael Doyle from the University of Sydney, a Bardi man, and leads First Nations health research at the Eden Collins Centre at the Sydney University Medical School, very focused on prisons, prison rehabilitations, and social and emotional well-being programs for Aboriginal and Torres Strait Islander people. Please welcome our panel. The Slido QR code is up there. Feel free to make comments, ask questions as we are going on. I will try and bring them into the conversation as we go in real time, rather than waiting till the end. Mel, You haven't got anything to say, have you? No. Okay. So Mel brought a laundry list, literally a laundry list, to talk. So don't get too nervous. I think.
Is this on?
It is.
Yeah. Morning, everybody. Lovely to be here with you. I have written some stuff down. I'm not great off the top of my head, but anyway, here we go. So as Norman's alluded to, we've talked a lot over the years about the importance of science in public policy. And as we all note, it's been to good effect in the AOD space over the last 40 years. But in more recent times, bigger issues of the role of politics and the impact of broader social trends on the capacity of science to get traction have really come into stark relief here, and incredibly so, as Norman also alluded to, in the US. In particular, the well-documented decline in the trust in public institutions and in public in general that's been spurred on by growing inequalities and social distances, and that has in turn led to deepening political polarisation. When the AOD strategy started 40 years ago, we had the same political parties as we've got now, plus or minus the Greens and a few independents. But there wasn't a huge amount of distance in values between them, even in Queensland, where I grew up, where there was a very conservative, long-standing National Party government.
We invented Donald Trump before Donald Trump was invented.
Joe, that's right. But they were economically conservative, and on the face of it, they were socially regressive, but in practice, in things like needle and syringe availability, for example, and getting money into an AIDS council when that was needed, which they did through the clandestine means of giving it to Sister Angela Mary Doyle, Sister of Mercy. They were socially pragmatic, in fact. In that context, the role of science in public policy was easier to prosecute, both to governments and to the public more generally. People talk about getting the science right, but also more recently, in the face of major assaults in the US on academic freedom and on free speech, we also need to ensure to get the right science. When words and a focus on particular, this is where the laundry list isn't good, words and a particular focus on particular groups get banned or not funded, we're in real trouble. So 40 years on in Australia, with increasing political polarisation here too, we need to really start to focus not only on getting the science right, but also making sure we keep getting support for the right science. By this I mean we need to get a lot more interested in the study of the interplay between values, culture, how science and information is received and acted on. Australia is now 40 years on a much more multicultural society. Social inequalities are arguably much higher and broader, and with the consequence of that, the politics of division and envy are getting much more traction. We need to understand the determinants of trust in science and science literacy as it relates to things like alcohol and other drug-related harm, how characteristics such as worldviews, identity, motivations and risk tolerance shape how people, including politicians, interpret and use our research to make the consequential decisions that affect us all. Just raging against the machine when things happen, like legislating to ban pill testing recently in Queensland, or lowering the age of criminal consent to 12 in at least 2 jurisdictions isn't enough. When we started 40 years ago in drug policy, and then when HIV/AIDS hit, we did have a golden era of evidence-informed public policy, interest in investing in science that would improve it, and so on. Robust national and often state-based whole-of-government response structures across ministerial portfolios, and monitoring and evaluation built in for continuous improvement. But now we have no state, territory or federal government multi-portfolio governance structures. We have no long-term commitment to the research centres as they stand now. In a way, we've become a victim of our own success, and alcohol and other drugs as a priority of governments has declined significantly, except to put out spot fires after disasters, high-profile tragic losses, and community meltdowns in some places. Probably most importantly, the biggest threat to evidence-informed public discourse, personal beliefs and public policy is the huge changes over the last 40 years in the way people access information through social media platforms. That really didn't exist when we started. In the early days, we would brief key health journalists, of which there were only a few. We would buy episodes of shows on the ABC, like Jeffrey Robertson's Hypotheticals. We would buy and work with writers of soap operas like Home and Away to get messages out that aligned with evidence. We developed talent banks of attractive, charismatic experts, such as Professor Eli to my left, to be interviewed on current affairs programs. We ran education programs, the whole social marketing toolkit that was available to us at the time. But now these things are more often than not swamped by mis and disinformation through highly targeted social media. All this coupled with the decline in the capacity and revenue of independent media and professional journalism makes our task even harder. We still have the great foundations of data and research we began building 40 years ago, but we're going to need to protect it and get smarter at the science of translation of evidence into practice and policy by understanding these dynamics that threaten to swamp our capacity to get cut through in the future.
Thanks, Mel. Michael, you judge a policy in many ways by how effective it is at the pointy end, where things are toughest. And you work in an environment where things are tough, the prison environments, and with disadvantage and with Aboriginal Torres Strait Islander people. Does our current framework for policy in drugs serve First Nations peoples to the extent it should?
Thanks, Norman. We can have the right policy settings, but it's the implementation of that. And I think Australia's the framework that we have, the harm reduction, you have supply reduction, demand reduction, harm minimisation. I think the actual framework is fine, and that works quite well if you think about the components of it. But it's the way that's implemented and then how community then owns that. And part of the issue that I see that's happening now is Aboriginal people don't feel like they own part of the National Drug Strategy. We did when there was NIDAC, National Indigenous Drug and Alcohol Committee. We don't have a national committee that is identifiable to us. There are great people on the national committee. I'm not having a go at the individuals, and there are people on the committee. We've had Aboriginal people on the committee, and we've got people on the committee who are fantastic, who are very well known in the community. But when NIDAC was done away with in 2015, there was this absence of leadership, and that's still sort of the pervasive, the predominant sort of thing that's happening in that particular space at the moment. I'd also say...
So before you go on, I mean, there were clearly leaders then. What happened to them? Did they just lose the sort of power pathways that they had?
So at that time, a whole bunch of things. This was the Hockey Abbott government, and Joe Hockey cut lots of stuff, some really good things that were very meaningful. If Aboriginal and Torres Strait Islander people do not feel like we own part of the national strategy, how could you possibly expect us to sort of take that on board and work in that particular direction? And at the moment, I think that's what's happening in that space. And there does need to be a real think from the federal government around that. We did have a referendum in 2023 because apparently the government at that point in time thought Aboriginal voices were incredibly important in decision making, and we currently don't have that. The other thing we'll see with Aboriginal people being involved in the most senior levels of policy setting, most of our community are in one way or another directly affected by the issues for which we try to seek solutions. So my family, possibly myself, may have personal experience in some of these things, and that in itself becomes sort of a peer type engagement within the policy. Also, just to say another thing that I think is really, really important is that We have closed the gap, and I think close the gap is really good. I really do. But the problem is we have growing disparity in the whole of Australia. And so we have this policy where we're going to close the gap in disparity with this particular group, but we're going to let the rest of it just get bigger and bigger and bigger. And so our overall policy in this country around how do we tackle growing disparity as a nation is needed if we do genuinely want to close the gap between Indigenous, non-Indigenous Australians.
So some people would say we don't need another minute of research on disparities. What we need is implementation and understanding the evidence of causes. Do you believe that at bureaucratic level, when you're talking about implementation, at bureaucratic level, at state and federal level, there's understanding of that evidence, or are they flailing around?
At the bureaucratic level, yes. Yeah, it is my experience. In New South Wales, I work fairly closely with our Centre for Alcohol and Other Drugs. I think they have a really good handle on it. I think there was an acknowledgement that they could have been doing better, and I think they are doing better, and it's gone from strength to strength. I really think we're moving in the right direction. I congratulate our bureaucracy in New South Wales for their work and the changes that have been made. Not every bureaucracy at the state levels are the same as ours. I would sort of go back. I think there's a fundamental difference in Sydney as well, if I might add, in New South Wales. I think the HIV epidemic changed the way in which some of the drug policies operate in New South Wales, is sort of my theory on it. I'm sure others have their own theories. But you look around the whole country, and New South Wales is a bit different to other places. And I think it's the leadership that we got through that epidemic, through the work like places like NUAA, ACON and other organisations who really advocated to having the affected community part of the
So let's imagine, I just want to stick with this for a while because it's so important, but let's imagine a centralised structure is recreated. What would it look like, and what would its job be? What's the argument for it? I mean, I can hear the argument for it, but how would it work in practice?
Oh, look, I would have a serious look at the NIDAC structure and look at how that would be re-implemented, how you'd bring back a national Indigenous Drug and Alcohol Committee. That's where I would start with that. I would also say, speaking of structures, and this is sort of stepping slightly to the left of what you're talking about, Norman, is we continue to look at individual solutions for somebody who might be affected with drugs and alcohol or going in prison and those things. But we're not necessarily tackling the structures that are continually sort of producing more people in that situation. And so a new policy setting would be, well, what are the structures that we have in place? So is it the criminalisation of people going to criminalisation of being poor, basically. If you're not well off, you're more likely to go to jail. And so things that were not previously offences for which you can be imprisoned are now offences that you can go to jail for. And so there's been changes over a long period of time that have sort of criminalised a particular group, and it has this way of feeding on itself.
So you need a broad, the old cross-sectoral thing, but you need a broad church to be involved. And just give me the current stats in terms of, the prison population, the Aboriginal, Torres Strait Islander prison population, and how much of that is drug-related before they came into prison.
Okay, so it's somewhere about 2/3 would in some way have had some form of alcohol and other drug use issue, possibly a bit more. What's important about that, though, is that I wouldn't necessarily say one leads to the other. I think both of those things are kind of happening at the same time. People will say they're less likely to have committed an offence if they weren't using drugs or alcohol. But the over-policing of Aboriginal people is a major issue. There's lots of people who use drugs and alcohol. It's just Aboriginal people are more likely to be locked up.
The slammer, yeah.
And so there are a lot of overlapping factors. But when we look at the criminal justice system, it is the too hard basket. is the people who end up in prison are the ones, usually the people who everything else is kind of, they've slipped through all the gaps, and prison is like the safety, or not safety net, but is the place where they've ended up. And then we try to work with that particular group at that point in time.
And I'm out of date. I presume the prison officers are still blocking needle exchanges in prisons? Yep.
Yeah. I'll comment on that. This is the evidence is so strong, but I think we just name it what it is that the real challenge of getting NSP into prison is about how do you deal with the officers' union. That's where they will not have a needle exchange. There's plenty of needles in prisons. Needles everywhere in prisons. But the officers' union will not come at the idea of having a needle exchange. And there needs to be further work with that particular group. We can talk about the rest of it, but until they're on board, it's just not going to happen.
So Mary, in terms of your territory, people living with AIDS, drug users and so on, what's your perspective of where we stand now? I want to get a sense of where we are now, where we need to be. Michael laid that out very clearly in terms of First Nations communities and the prison population. Where are we now with it? And where do we need to be?
So where are we now is, I mean, in New South Wales, I mean, it's interesting, and I'm glad you brought up the HIV response initially. And, you know, I work across both spaces, bloodborne viruses and alcohol and other drugs, because our organization gets funding for service delivery in both spaces. And there's a very well established and set up network of organizations working in those spaces, and they don't have the same traction in alcohol and other drug spaces. In New South Wales, it's quite good, but it's very patchy nationally. And so, you know, the involvement of people with lived and living experience is well, it's underfunded across all of those spaces, but in alcohol and other drugs, it's quite new, it's quite underfunded. We don't have structures for workers. We don't have like worker organizations to support people.
So you're talking about at the peer level rather than structurally?
At the peer level. So, I mean, structure, and I'll tie into what Michael said, and there's no real involvement of people who've lived in living experience in the governance nationally. You know, it's that I think is something that we need to have happen, and we need funding to support that involvement. I mean, in terms of the strategy, I mean, I'm with probably everybody else. I think harm minimization is a perfectly great framework, but, you know, we talk about harm reduction, but it's got an absolutely minuscule amount of the funding. And it 1.6%, and we pour all our money into enforcement. And that's, you know, a direct result of criminalization and stigma, right? Like there's still a lot of stigma in terms of the way we implement policies. And, you know, NSP in prison is a great example. We're not going to eliminate Hep C without NSP in prison, and it's continually blocked. So until we actually have, and we're doing a bit better in New South Wales, but until we have like a consistent bipartisan approach to these issues and harm reduction, I mean, there's a bipartisan approach to harm minimization, great, but when it comes to harm reduction, people pull back and, you know, they want to kind of shove it in the corner. They don't want to fund it. And, you know, it's like what happened in Queensland. It gets taken away very easily. It's very fragile. Like our belief and our investment in actually supporting people who use drugs.
So is a bipartisan approach a feasible goal in the current world rather than just courage to do what you know is right? given the polarization of politics. So you've got a moderate and running the Liberal Party, the Liberal coalition at the moment, but she's not going to be there that long, and somebody who's far more conservative than her will take over. And electorally they'll suffer the consequences, or may not, depending on the charismatic nature of the new leader. But bipartisanship here seems ephemeral, and if you're going to wait for that, you're going to be waiting a long time, and the drug strategy is going to fall apart.
Yeah, I mean, I think that's a fair point. I don't know that Australia is going to go the way of other countries. I think that's a...
Excuse me, we've got a man on the loose who murdered a couple of cops, and it hasn't been found, and it's probably been protected by...
In terms of our political parties, though, I think that there's a difference, like, yes, that stuff is happening here. There was a protest right outside our offices a couple of weeks ago, But, all right, leaving aside the question of bipartisanship, I don't really have the answer to that. I think there's signs both ways here, right?
I'm not going to let you go on it, because if we wait for it, you could, things could fall apart a bit in terms of a coherent strategy, at least get going, and if you have evidence behind it and show benefit, then you might drag people along. But if you're going to wait for a negotiation in the current environment, much easier 40 years ago to get bipartisanship, I suspect, than now.
I mean, I think that the strength of the current national approach is that harm minimization is kind of a done deal, right? And the difficulty is more the way we implement that, and the very poor implementation of harm reduction versus law enforcement. And no, I don't know. We may someday live in a world where people who use drugs aren't essentially political footballs. I don't think that's going to happen anytime soon. But I think that, we can make commitments to increasing funding and support, not only for harm reduction, but for people with lived and limited experience to have involvement in these structures. And, politics changes, like that we see that every day. We just saw that in Queensland. But we can only do what we can do, and making commitments to funding those things would, that's kind of the best we can do at the moment.
Let me play the devil's advocate for a moment in terms of funding, because it's the cry throughout. So I'm somebody who holds funding. I give you more money. How do I know it's being well spent on effective structures, in a systems approach? Just putting money into the system. So if there was more money available, are we guaranteed that where it's going to be spent, particularly in not particularly, but in your area, that it's going to be spent well with measurable results?
Yeah. I mean, I'm not sure I understand the question, to be honest. Like, so are you saying that we are unable to measure what we do, or?
Michael, do you want to?
We've seen demonstrations of withdrawal of funding. And so in Queensland, there was a withdrawal of funding for sexual health services for Aboriginal people. We then had an epidemic of syphilis that was still trying to get under control. And so you would have to say that the current level of funding that we get, which isn't enough, if we didn't have NUAA and these initiatives, we would probably be seeing overdoses all the time. We'd be seeing all kinds of issues that would start to emerge. If we added some extra funding, we could possibly push some of these issues back further, provide more education, and do more in that space. If we're saying if we invest in that, then we'll see benefits, but in some ways you may not see that directly in a measurable way as well, I would say.
Can I just, so the rate of HIV in Australia among people who inject drugs is maybe it's very low. It's the lowest in the world, or equivalent to the lowest in the world. And there are other, places without NSP, without opioid treatment program, where 17% of people who inject drugs have HIV. And, that's a measure of the value of money with, that tiny amount of money that harm reduction and peer orgs get, that they've achieved that. And I think that's we can't really forget how important that achievement is. And it was achieved by people who inject drugs. And we know that harm reduction services are incredibly high value. For every dollar you put in, there's a total of $27 investment return for something like a needle and syringe program. So I think that the value is actually well demonstrated. And but they are compares to other parts of the three pillars, the amount of money is quite minuscule.
Robert, Mary said harm minimization is a done deal. Is it?
In the community, I don't think it is. I think that there's a disconnect nationally between what policy advisors know to be worth investing in, what communities understand as being the problem, and the plausible solution. I think that fear of complacency is the one that I hold nearest to me, because we have been incredibly successful, but then we've seen a systematic degradation of our commitment. Bipartisan support's important, but we live in a federation, and we shouldn't forget that the states and the territories can't agree on anything in a coherent way that enables a national approach. If you look at the national strategy, it's actually a shell game where we cherry pick examples of excellence, but we don't actually go to get a unified commitment for implementation. So in that process, what has happened now, I think, is that we're starting to question whether we're heading in the right direction, whether there are better examples and opportunities of implementation from overseas that we should be mirroring. And such as there's been a great emphasis, I think, nationally on reconsideration of primary healthcare reform, trying to become more coherent, more team-oriented, more integrated into the digital network. And we're outside that space. We're not even seen as core business of that space. And when you try to move into the preventive health arena, we present 2% of budget goes into prevention. 5% would be a realistic approach and comparable to other comparable countries. But we continue to think that we're the exception rather than the rule. And then we conflate things. So we start to say mental health approximates AOD problems. Why don't we just put it into there? So I think the problem that I can see is that we don't have a national coherent approach. It continues to be rivalry at a jurisdictional level, and a failure to grasp how successful we've been and build on that success. And it gets back to the point that I think you made earlier on. We don't have real-time data monitoring. We rely upon large data sets to guide public policy, but we shy away from enabling early warning systems that would tell us when things aren't going right. And to me, politics is a lot about crisis, right? The whole thing was Bob Hawke's tears. He came up with a solution that was the wrong solution. You're right, it got turned around. Neil Blewett was part of that process. There were others that were involved that talked about a structure and a framework of how we should be responsive to this. But in that process over time, the meaning of that, the crisis, the feeling of needing to come together, the needing to all be on the same page is dissipating. Maybe the new crises that are emerging now with the threat of illegal tobacco might be a clarion call to reconsider it. But I'm desperately concerned that now we start to believe that we're not on the right track, and we're certainly not part of the main game.
Norman, sorry, the thing that I hang on to is that at the time of the initial strategy, we didn't have wall-to-wall progressive governments, and yet we did get to the point where, in practice, sometimes not in political rhetoric, we did get a unified national approach that was pretty evidence-based.
Well, you had a Conservative government in Victoria, which was far more radical on drugs than most Labor governments.
Exactly. So it is, the other thing I think that's happened and is starting to be turned around, which I think is a fabulous thing, is over time, the policy grunt of the public sector at state and territory and Commonwealth level was degraded by a range of decisions about just the nature of, the public service, and that you would outsource a lot of the functions, policy functions, to the commercial world, or, just didn't maintain that capacity for deep policy analysis and implementation in-house. We've seen recent moves announced by the Premier here to ban the use of consultants in order to start rebuilding the capacity for good public policy internally. And I think, and there's been similar moves at a federal government level, and as someone who has been in the commercial world doing commission research on and off for 20-something years, but now back in academia, I think those are enormously positive moves, because to get the kind of joined up stuff across states and territories, it took a lot of work in the committees like the one Michael's talking about in the Aboriginal Torres Strait Islander area. Robert chaired the National Illicit Drugs, which was a mixture of experts and senior public servants. There was one on alcohol, there was one on tobacco. And, the strategy and policy activity was constant and constantly informed by evidence, but supported by the policy grunt of the public service. And I'm heartened. And those women and men who dedicate their lives to real public service are a big influence. They manage upward well when they are, in this increasingly returning climate, I think, to influence the politicians. So it's a two-way street. I'm optimistic.
Are you?
Yep.
I'm getting depressed. Doesn't sound as if we've got a national drug strategy from what you're all saying.
Well,
It's on paper.
We've got one that...
Well, it comes to Michael's point, it's all about implementation.
Yeah, and with no bottom line, no commitment. I think the National Preventive Health Strategy, alcohol and other drugs, was a late inclusion, and it required advocacy for its inclusion. The failure to have our optimism that things could be changed took a lot of convincing. The new strategy is being delayed. These things take time to work, but there's no overarching governance structure within governments and across governments, within portfolios and across portfolios, that come together and see this as an important deal.
So there's an interesting comment on Slido here. Let's have a performance framework developed collaboratively, invest in data governance with the right people at the table to measure meaningful outcomes. I'd flip that comment to say, is one of the subversive things that could happen here about data to build the burning deck? and that we're not doing enough with data that are available. And we have increasing ability, without necessarily government getting involved, to link data in a secure framework across the system. And is that one of the things the sector should be doing?
And I think that, there's a lot, if you look at Louise's work and NDARC's work and others, a lot of the data is there. It's how it's used persuasively. It's not just the presentation of facts and figures. Some of the big policy breakthroughs that I've witnessed have been where certainly you present all that data and you have the data, but then you intermingle that with, trying to promote the enlightened self-interest of people who framing it in a way that makes sense to people, even though they might be deeply conservative as opposed to progressive. So I think the data stuff is always really, but it's the necessary but not sufficient thing to get the change.
Yeah, I think there are really two domains. There's big data sets which help to identify emerging threats and adequacy of existing responses. I think those data sets we do incredibly well. Where we miss the boat is at the individual level, and there's pushback from vested interests who don't really want access to real-time data about individuals so that we can get targeted, meaningful, compassionate care for people. We don't have a quality framework. We don't have an accreditation framework for service delivery. You trust your arm, or you ask somebody's advice about, is that a good service to go to? So at the moment, yes, there are data sets that are available, but I don't think in the digital era, listening to the conversations last year about trying to get primary health care's buy-in for access and sharing of data that would help improve treatment outcomes, there's resistance, there's uncertainty about privacy issues, but there's also uncertainty about how that will be helpful and whether rights of professions will be eroded, giving up the space.
So what about community-controlled health organisations? Are they setting an example, or are they running away from it as well?
So I think in terms of clients, they need a choice. So not everybody does want to go to an Aboriginal community-controlled health organisation, I'll say, but you should have the choice to be able to go there if you'd like to.
That's about 50% of Aboriginal people would go to an ACCHO.
Yeah. I work very closely with community control. I'm very involved with the state peak body here in New South Wales, but having a choice is a good thing. I think people feel safer when they go to Aboriginal community control services. The fear of discrimination based upon your race is no longer an issue, but you may still have fear of discrimination based upon if you're a drug user or being judged in those ways as well.
But my question was picking up on what Robert was saying, which is that primary care in Australia is hesitant to buy into this whole policy area. So my question about the community-controlled health sector in Australia is, are they providing leadership here, or they're nervous too?
Oh, okay, that's a big question. I would say yes, but on a localised level, and there's not a structure at present, once again coming back to not having a NIDAC sort of committee, there's a lack of a structure to have a coordinated way within to do that. So we don't have a New South Wales strategy. There's not, and there's very little buy-in for the national strategies. So yes, to buy into the sort of primary healthcare, we would need to have that in a more coordinated way so organisations can network. I want to reflect on one other thing you said about the data. So if the national data says about 18% of people presenting to drug and alcohol specialist services in this country are Aboriginal and Torres Strait Islander. So that's about 1 in 5. That's what the data's saying. Is Australia spending about $1 in $5 in the drug and alcohol space toward Aboriginal, Torres Strait Islander drug and alcohol? So we can have the data, but it doesn't necessarily translate to the level of support to the most affected communities. So you might think we get a lot of funding in Aboriginal drug and alcohol, but we actually, the level of need is much, much higher, and the level of funding we have is just not enough for where it should be.
And drug users is a similarly isolated group in terms of having a powerful argument. Or you have a powerful argument, what I mean is a voice, really.
Yeah, I mean, I think the question of data is a really interesting one, and we're talking about linking up data systems and making it available. And in New South Wales, we're working on a single digital patient record at the moment. And I think the real fear for people who can be very isolated within their own communities is that having their record on file and public is that, and accessible across the board, is stigma. And that is, I think, the key thing blocking people from accessing services and care, particularly in general practice, as you're talking about. Like, it's very, very common to go into a general practitioner's office and see a sign that says, we don't prescribe, blah, 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 drugs.
We don't have drugs on the premises, yeah.
Yeah, and it's an automatic red flag for a lot of people. I'm not safe in this setting. I'm not going to talk about this problem. I'm not going to, and so, the people living in the community are incredibly isolated, incredibly vulnerable to all kinds of forms of stigma. We have an annual forum that we just had, and 2 different people came up and talked about how information that was in their medical record followed them for years and had incredibly significant impacts on their life for years because a clinician, 10 years ago described them in a particular way. So that's the risk for us as people that have lived experience is, it's like all the things you have to balance out in terms of like making the system work and having it like work for people.
So what I'm hearing is we've got a strategy. We've lost national structures that have an implementation path. We've lost consistency, which means that the services that you get, the preventive effort in communities varies, so it's not uniform across Australia. And that I'm hearing that we're wobbling on leadership. So the question here, which is, I've lost it actually, but the point was, if I paraphrase it, was I'm not sure that the new leaders emerging in this area share the optimism of the panel. I thought, what panel discussion have that person been listening to in terms of optimism? But nonetheless, it is an important question in terms of we do have tomorrow's leaders or emerging leaders in the room. What's their task? Is it, who do they influence? Where do they go? What do they use to influence? Because I'm not getting a strong feeling that we are on solid ground here. So what's the advice for emerging leaders? You're the one who's the optimist, Mel.
Well, if I was in...
Because I don't want this to be a downer for the rest of the conference.
No, I mean, I am optimistic by nature, but...
But you're going to have to put something in place. You're going to have to galvanise. You're going to have to do something to make it better than it is now.
Yep. And I think that the increasing rebuilding of the policy capacity within the public sector is already, in many parts of the country, giving people in the sector a place to go to, people to go and lobby and talk to at the bureaucratic level, and then getting their support and advice about how to have the influence at the big P political level. So that's one of the reasons. I think we're rebuilding a base of policy capacity, not only in alcohol and other drugs, but more generally in the public service. Now, that could all fall apart, but at the moment, and perhaps a clear run for the next 6 years or so, will allow the rebuilding a strong believer in public service, and that's the basis through which we can get some real change and re-stabilise the drug strategy, because it'll have something to sit on. You know, it'll have people who go to work every day whose job it is to consistently present evidence, to consistently talk to people like NDARC. NDARC talks to them. They take it forward into the political process.
Yeah, my view would be the importance of infiltrating and integrating into those systems that will make a difference. So, Australian Institute of Health and Welfare has taken on a greater role in that preventive health approach. They've got a dashboard. It can be enhanced and improved. There are opportunities to use smart people who are good with data sets to develop credibility with those, because those things show what you do matters. Governments don't want to invest unless you can demonstrate a return on investment. And at the moment, I don't think we're good at articulating that. So my optimism is that I know that we are quite innovative in our ability to use and construct arguments based upon solid science and solid data. We need to be more open and better advocates for that. And I think it's also critically important that we learn what we've lost and try to rekindle interest in it. There was a time when we incorporated into undergraduate education alcohol and other drugs. It's no longer there, and it just slipped away. Future leaders beyond you need to have enthusiasm, and if you don't see it as your core business, you're not going to do it. So I think we really need to start way back there as well.
There's a question here about CALD communities, culturally and linguistically diverse communities, and whether we just missed the boat on them. Do you have a comment on that, Mary?
Whether we've missed the ball in...
Well, just we don't have the focus we need. That's the implication in one of the questions on Slido.
I think that's a good question, but I would never say that we've missed the boat. I think that within those communities...
Well, I'd use the phrase "lost the plot."
Lost the plot. Oh, don't confuse me, Norman. So you know, I think that from my personal perspective, people with lived and living experience, we're kind of, and in terms of like optimism and what you tell people in the future, it's like something that's actually only just starting to gain traction within policy spaces. So, you know, NUAA as an organization started participating within AOD policy spaces only 10 years ago. And, you know, that it's like a hard slog to get there and get representation. But I think there's a very great awareness among a lot of people that we need those people at the table. And I speak to leaders from, you know, I was talking to an imam from Castle Hill yesterday who clearly sees the problems in his own community and wants to address them. And, you know, it's a matter of working on making those connections and bringing those voices forward. I mean, it's something that's done incredibly imperfectly, but the space is there for people. And it's up to people that are at the table, like myself, to increasingly make space for others to come and participate in those discussions.
Michael, without articulating it too much in this discussion, it has the feel of all we've been talking about is illicit drugs in this conversation, even though that's not been explicitly stated. You know, people who are ending up in jail and drug users and so on, and focus on illicit drugs. Do you think we're sufficiently focused in a national drug strategy on the high burden problems, alcohol and tobacco in particular? I mean, we failed to get volumetric taxation on alcohol. We've been talking about it for 40 years, and still it's cheaper to buy water in some Aboriginal cask wine in some Aboriginal communities than water.
There is a long way to go in that space. I presented the other week, I can't think of the exact numbers, but the burden of disease for alcohol over drugs, including tobacco, as well, is something, I think I said it was 29%. This is at the addictions conference down at the convention centre. And it worked out to be almost double that for the rest of Australia. So the burden of disease through drug and alcohol use, including tobacco, is almost double that for Aboriginal and Torres Strait Islander people. Tobacco, we need to do a lot more work in that space. I think that we need to have a really quite a rational conversation about a nicotine replacement therapy, NRT, and the way in which that's administered seems to be a big issue.
Comes back to general practice.
Yeah, and so vaping is a really bad thing is what we're being told now, but if you've been a smoker for 20 years and the only way you're able to stop the tobacco is by actually vaping, that's actually a pretty good thing for that person because that's gonna be good for their health. So saying all vaping is bad, which seems to be the message that we seem to be putting out, is not quite where that should be. We need to have a bit more of a nuanced and thought through strategy upon that. I did want to reflect on your part about the leadership that you're talking about and emerging leaders. And this is the NDARC Symposium. I remember being a PhD candidate coming along to NDARC Symposium being, wow, look at all these flash researchers and all of that. Reflecting on that, some of the people I became friends with, I still work with in different ways. And so we need more Aboriginal, Torres Strait Islander drug and alcohol researchers. But I would encourage the early career researchers that if you do have in your extended cohort Aboriginal, Torres Strait Islander colleagues, try and hang on to that friendship. Not for the purpose of I'm going to use them to get grants and stuff, but it's a really helpful link to have to build those connections as you go forward, and it might enrich the kind of work that you do into the future.
Interesting question here about the CDC claiming that it doesn't have alcohol and other drugs in its purview, even though it's a public health entity.
New one.
The new one. Well, we didn't have an old one. This is a new one, really.
The being established one, I mean.
Yeah, focus on infectious disease when the burden of what we're talking about is arguably higher. Do we need lobbying to revisit terms of reference of the CDC?
The curious thing about the CDC was that when it was conceptualised, tobacco definitely, alcohol probably were in scope. They were seen as major causes of public health concern, and they intersected with the other areas that they were concerned about. The National Preventive Health Strategy identifies it, that the linkage point is obvious. For governments to not grasp that is bizarre.
And in a way, while having all that national governance and in some states and territories specific interdepartmental committees looking at alcohol and other drugs, again, I think some of what's happening now is we are the victim of the success of that. People went, oh, someone else looks after that, therefore this will focus on infectious diseases, for example, that it did run very strongly, very successfully in parallel to a lot of and separate from a lot of the rest of national health reform, and so on. Discussions about funding policy. We had our own, alcohol and other drugs had our own national cost-shared funding program, and work went into that, whilst big hospital funding agreements just barreled along separate from. So an unintended negative consequence of how well all that happened is, and the success we had was that we got left out of some of those forums or fell off. I don't know if you think that's right, Robert, but that's my observation of the broad arc of the history.
So, a bit of a job to be done. People in this room and others around the country need to come together almost like a guerrilla organization to work out how to increase the impact of the data that we have. We need large organizations to be brought in under scope, which is colleges in the primary care sector and the federal government, which funds primary care, to be more focused on this area, and maybe loosen up on some of the policies in terms of tobacco, but tighten up others in terms of taxation and alcohol. I mean, some of these things have just been going on too long, and you come from South Australia, that's the reason why we don't have volumetric taxation of alcohol.
Well, I mean, it's true, and you know, the vested interests of industry, they talk to the people that hold the purse. Treasury is really the main game. Health is a minor player. Social and structural determinants of health swamp what our contribution makes to the health and well-being of community. And the fact that we still have industry able to influence and lobby government policy infiltrates across all of the arms of government, including health.
Except big tobacco is now increasingly criminal. Please thank our fantastic panel. We're going to rise up, but you need to organize. Thanks. Our next presenter is Dr. Rachel Sutherland, who's a Senior Research Fellow at NDARC, and currently holds a National Health Medical Research Council Investigator Fellowship, and her program of research is focused on monitoring systems for detecting trends in illicit drug use, so in other words, on message in terms of what we've been talking about, including new psychoactive substances, which we didn't get round to talking about in the conversation there, and developing and evaluating novel responses to emerging drugs of concern. Rachel is currently Deputy Program Lead for Drug Trends and Program Lead of the Illicit Drug Reporting System and Ecstasy and Relating Drugs Reporting System. Please welcome Rachel.
Fantastic. Thank you so much for the introduction and for that really insightful and engaging discussion. So I am going to change tack a little bit, and today I'm going to be presenting some of the most recent findings from the Drug Trends program of work. Before I do that, I would just like to acknowledge the Gadigal people as the traditional custodians of the land on which we meet today, and pay my respects to elders past, present and emerging. And would also like to acknowledge that the program of work that I'm about to talk about is a national program that involves lots of different people from across Australia, and to thank the thousands of people who use drugs who have shared their kind of knowledge and experiences with us over almost 30 years now. And of course, thank our funders from the Department of Health for their support of this program of work. So very briefly, for those of you who may not be familiar with Drug Trends, as I said, this is a national program of work that's been running for almost 30 years now, and its overall purpose is to monitor trends in drug use, drug markets, and drug-related harms and behaviours. And we do that through a number of different ways. So every year we conduct surveys with people who use drugs. So in particular, we conduct surveys with people who inject drugs and with people who use ecstasy and other stimulants. And these are recruited from every capital city across Australia. And they're not representative samples, but rather they're sentinel samples who are kind of regularly engaged in drug use and drug markets, and so who may be more likely to pick up on changes. In addition to that, we also analyse existing data sources, so in particular, drug-related hospitalisations and drug-induced deaths, but we also look at other data sources such as treatment episodes. And then we also have the DNET program of work, which involves largely analysis of online data sources, in particular, regular kind of snapshots of crypto markets and the drugs that are listed on those marketplaces. So I don't have too much time today, so I'm mostly just going to be focusing on opioids, stimulants, and then talking a little bit about tobacco and nicotine. So as I'm sure many people here would know, a few years ago, the Taliban banned opium cultivation and production in Afghanistan, and we saw almost immediate reductions in opium production globally. It has been estimated, and there's been a lot of questions around what impact this is going to have on opioid markets globally, so both in terms of heroin markets, but also emerging synthetic opioid markets. So it has been estimated that there was enough opium kind of stockpiled to last until about the end of 2026. But on the other hand, the most recent World Drug Report has reported kind of early indications of supply constraints. In the Australian context, most of our heroin does come from Southeast Asia, where there's reportedly still ample supply to meet Australia's demand for heroin. So what did we find in terms of our surveys with people who inject drugs? Essentially what we found is that heroin use and markets continue to be relatively stable, and there doesn't appear to be any evidence of disruption. So this shows among our sample of people who inject drugs that heroin use and frequency remains kind of common and stable. And similarly, looking at the wastewater data, which is at the bottom of the slide, we can see that estimated heroin consumption at a population level has remained relatively stable. And similarly, in terms of market characteristics, again, if we look at our surveys with people who inject drugs, we can see that most people continue to report that heroin is very easily accessible. And in fact, this year we actually found a significant decrease in the price of heroin, so back down to $50 for a point, which is what we were seeing back in 2019 and prior. And this is in contrast to what we are seeing in Afghanistan, for example, where they have started to report an increase in price, so that the price in Afghanistan and neighbouring countries has tripled. So as I mentioned, there's also been a lot of concern and interest around synthetic opioids or novel synthetic opioids. And as we can see here, the number of new psychoactive substances that fall within the opioid class has increased substantially over the years, peaking in around 2021-22, but then we've seen that kind of drop off in more recent years. But what we can see is that drop off has really been driven by a reduction in the fentanyl and fentanyl analogues, and we are seeing that increase in nitazines being reported. So this is just the number of NPS reported to the UNODC. Sorry. And so this is fairly consistent with what we see in Australia. So if we look at the No, which is a collation of drug alerts from across Australia, we can see that there's been almost 40 nitazine drug-related alerts over the past few years, but in contrast, we've seen very little alerts kind of relating to the fentanyl or the fentanyl analogues. In the Australian context, much of the nitazine use appears to be unintentional, so it's being detected in like counterfeit substances, counterfeit oxycodone or benzodiazepines, but also in drugs like ketamine, cocaine, MDMA. And so in this case, it's useful for us to look at the crypto markets to give us some insight into the nitazine markets. And what we can see here is the number of nitazine listings on crypto markets, on English language crypto markets, over a period of about 3 or 4 years. And we can see there's been a lot of noise over time, but so this goes up until August, so last month. We can see more recently the number of listings has started to decline. And similarly, we see the proportion of nitazene listings that ship to Australia has also dropped off. And it's unclear, but this could potentially be related to shifts in the geographic origin of nitazene listings. So earlier on, a lot of the nitazene listings were originating from Asia, and in more recent years, we've seen that shift. So currently, most of them are originating from North America. In terms of what types of nitazenes are being listed on these marketplaces, we can see that the isotonitazenes and the protonitazenes are the most commonly listed nitazenes on these marketplaces. And again, this is fairly similar with what we see in the Australian context in terms of the types of nitazenes that have been detected in Australia. But we can see that there are a range of different nitazenes that are available, some of which haven't yet been detected in Australia, but all of which do offer delivery to Australia. And this data is a little bit messy, but really the main point to note here is that there continues to be shifts in the nitazene markets and the types of nitazenes that are available. So it continues to remain a really dynamic marketplace that we need to watch. And for the most part, the nitazenes are coming in powder form, but we do see it being available in a range of different forms, such as pills and liquids as well. And so when talking about opioid use, whether that be intentional or unintentional use, I think one of the really good news stories to emerge from our surveys this year is around the increasing awareness and uptake of naloxone, both among our sample of people who inject drugs, but also among our sample of people who use ecstasy and other stimulants. And so the slide at the top shows naloxone awareness and uptake among our sample of people who inject drugs. And we can see that that's been just gradually increasing year on year over time. But I do also want to talk briefly about the naloxone uptake among our sample of people who use ecstasy and other stimulants. So this is a group of people that typically wouldn't use opioids intentionally, but who may be at increasing risk of consuming substances that are adulterated with strong opioids. And so really promising to see that in our most recent surveys, most of them report being aware of naloxone. And in fact, 1 in 5 had actually obtained naloxone in the past year, which I think is a really great percentage and a real credit to those working kind of in this area, and as well as to the take-home naloxone program. Just very briefly, in terms of methamphetamine use and markets, really the main thing to note here is that methamphetamine use and markets remain stable and high. So again, if we look at our surveys with people who inject drugs, we can see that that methamphetamine remains high and common, and over time we've been seeing that increase in the frequency with which people are using methamphetamine. And similarly, if we look at wastewater data shown down the bottom, we can see that there was a bit of a drop in estimated consumption during the COVID period, but in their most recent report, which went until about October of last year, I think, they saw that kind of estimated consumption level return to, and in fact precede pre-COVID levels. And similarly, in terms of market characteristics, we see that remains stable, so easily obtainable, and also consistent with what we see globally, where there continues to be an expansion of methamphetamine kind of production and seizures. And also just to note that in terms of methamphetamine-related harms, we can see that harms did increase quite substantially between 2010 and 2020, but again, that does appear to have stabilised in more recent years, along with strong treatment demand. And I will just end by talking about tobacco, nicotine and vapes. So as many people would know, there's been a range of legislation which has been introduced to try and regulate e-cigarettes or vapes. The most recent of those regulations were introduced last year, which prohibited the importation of disposable vapes, but which also led to a pharmacy-only model, so where people can only legally purchase vapes from a pharmacy, usually without a prescription except for the higher concentration of nicotine. But what we can see here from our surveys with people who use ecstasy and other stimulants is that it doesn't really appear to be having much of an impact. So virtually no one reported obtaining vapes from a pharmacy, but in contrast, almost 2/3 were reporting obtaining vapes from non-pharmacy locations, so most commonly convenience stores and things like that. And for the most part, they continue to obtain disposable vapes. Initially, there was some speculation that the changes in these regulations would lead to an increase in nicotine pouches, but we don't really appear to be seeing that, at least in our surveys with people who use drugs. So we do see that about 1 in 5 of our sample of people who use ecstasy and other stimulants reported that they had used nicotine pouches in the past 6 months, but they're really doing so very infrequently, so about once every 2 months, whereas for the vaping, people are using it much more frequently, so about every second day. So certainly don't seem to be seeing nicotine pouches replace vapes in any meaningful way. And finally, as was mentioned kind of at the end of that session, there is increasing concern around the illegal tobacco trade. And in contrast to general population samples, tobacco use has remained consistently high among both of our groups of people who use drugs for the duration of these projects. But what we are seeing is that of those who use tobacco, now the majority of them are using illicit tobacco. And we've only been asking about this for a couple of years, but it was a significant increase from last year. Among those who had used illicit tobacco, the majority of people were obtaining them from tobacconists or from convenience stores. They were mostly obtaining branded cigarette packs and paying about $13 to $16 for a packet of 20. And that's probably about 1/3 or less than 1/3 of the price of what you would pay for a legal packet of cigarettes. So really no surprise that when we asked people why they were using illicit tobacco instead of legal products, pretty much everyone was saying because they were so much cheaper. Okay, and that's all I have time for today. So we have released the 2025 IDRS and EDRS reports today, so they're available on our website along with all of the drug trends reports. We do also have a range of posters that are available that look at certain topics in more detail, and please do reach out if you have any questions. Thank you so much.
Thanks very much, Rachel. Now, we invite you to enjoy morning tea, and please enjoy the posters on display and vote for your favourite in the People's Choice Award using the link and QR code. And please come back by 10:50. So, thanks.